Good evening, one and all. I welcome you to today's webinar on response to mental health crisis of COVID-19 global perspectives. We have over 81 participants who have already logged in, and I thank you all for participating in such large numbers. I am Dr. Bhavika Vajawat, and it is my pleasure to facilitate this webinar. We have with us today our esteemed Secretary, Ministry of Health and Family Welfare of India, Ms. Preeti Sudan, who has been the key strategist in times of the COVID pandemic. We are also honored to have with us the stalwarts and icons of psychiatry and delegates, both nationally and internationally, who have graciously agreed to participate in this webinar, and we are all eagerly waiting to interact with them. So without further ado, I request our head of the department, Professor Pratima Murthy, to welcome this virtual gathering.
Hi, good evening to most people. I think many people have joined around the world, or either in the afternoon or in the evening. So good evening to all of you. I think it would be very appropriate to say that, we've never imagined in our lifetime that we'd be going through moments like this. Just a decade ago, we were rejoicing in the fact that the world was flat, and we were rejoicing globalization. And now we're at a moment where we're wondering whether the world is going to get flattened. And how are we going to manage the times ahead? There's been a lot of, emphasis on physical distancing. We've realized like never before the importance, despite physical distancing, we've realized for the first time in our lives, the greatest importance of staying connected, of learning from each other, of networking, of learning both what we should be doing and what we should not be doing in terms of addressing the pandemic. The COVID pandemic hasn't been just a physical pandemic in terms of affecting our physical states. It's really unleashed a whole lot of mental distress. We've known about the worried well, people with depression, anxiety, various kinds of psychological distress, uncertainty and anxiety. And particularly in marginalized communities, the effects of these can be extremely devastating. We also know about the economic kind of challenges that in turn can, aggravate the mental health problems. At the same time, I think we understand the importance of resilience more than ever. And in times of these uncertainties, how is it that we can learn how to cope? How can we be less vulnerable and come out of this stronger? That's where we need people to come together and try and see how we can find solutions. So so this is truly a webinar with a difference. We have a set of global stalwarts from Australia, Professor Mohan, from the United States, Professor Matcheri, Keshavan, from Canada, Professor Lakshmi, Yatham, from the UK, Professor Dinesh, Bhugra, and closer home, our beloved director, Professor B.N. Gangadhar, who are really going to talk about the impact of the COVID pandemic, not only in the countries that they're located in, but what lessons it has for the world. How do we address the public in terms of mental health? How do we look at underprivileged societies? What might happen after the pandemic? The common thread that connects, all the speakers is that the four of them are visiting professors in the Department of Psychiatry. We've never had an opportunity before to actually bring them together on a common platform. And this is the webinar that offers us this particular opportunity. And we're very, very glad to have them. Not only do they bring in the expertise of the countries they work in, they have mentored several young psychiatrists from India. And I'm sure the wisdom that they bring will help us to find, not only to understand the challenges, but to find solutions to this huge crisis ahead of us. The icing on the cake is, of course, that, as Professor Gangadhar mentioned, we have in our midst Mrs. Preeti Sudan, the Secretary, Health and Family Welfare, Government of India, and we couldn't have hoped for a better person to actually inaugurate this program after releasing the newsletter Samatvam, which was brought out by our Center for Integrated Medicine at NIMHANS under the leadership of Professor Gangadhar and Professor Shivrama. So she's going to do that and inaugurate this webinar. As all of you know, Bhavika described her as a strategist. And I think particularly, she's always been one, and particularly in the COVID crisis. Her leadership has been exemplary. She has a particular interest in mental health, has actually written about the crisis of mental health and what might be the factors contributing to it. She has brought about several people together to bring about material, awareness material, start a helpline, strengthen the state government responses to the mental health crisis, increase prevention of mental health problems, improve awareness, and importantly, reducing the stigma and the fear around COVID. So, Madam, we're very, very grateful for your taking time off to be with us this evening, and we really look forward to your inaugural address. We also have amongst us Mr. Nilambuj Sharan, Economic Advisor to the Government of India, as well as the Joint Secretary responsible for NIMHANS. And he's been extremely supportive to us in all our activities, and I'm sure has helped the Institute grow from strength to strength. So we'd like to welcome you, sir. And I will not stand between you and the speakers, but before I conclude, I'd like to welcome our large audience. You know, we've had about 300 registered participants. Many of them have logged in now. We're hoping that more of you will log in. And I'm sure this is going to be an intellectual as well as an emotional treat for all of you. And I hope you enjoy the 2 hours ahead. I'd like to thank, in a welcome speech, you don't normally thank people, but I'd like to thank Professor Naveen and the team for actually bringing this all together and bringing us all together on this platform. Welcome once again, and thank you all very much.
Thank you, ma'am. We now move forward to the release of a quarterly newsletter, Samatvam, from the Department of Integrated Medicine of NIMHANS. I hereby request Ms. Preeti Sudan to release Samatvam.
Very much, and it's my proud privilege to release this important. Oh, nice! It's a virtual release.
I thank you, ma'am. I request our esteemed Health Secretary, ma'am, to deliver the inaugural address.
Thank you very much, Dr. Gangadhar, Professor Pratima Murthy, eminent national and international experts, my colleague Nilambuj, participants, ladies and gentlemen. I think Professor Pratima Murthy really said very well. Humanity has actually rarely expressed and experienced such a collective sense of vulnerability. In fact, I would like to say that if we could express our experience of vulnerability more, maybe that will help us to overcome the stress and anxiety that all of us are feeling at this point of time. I begin with expressing my gratitude to NIMHANS, our premier institute dealing with mental health, and also all our national and international institutes that are dealing with very sensitive subject of mental health and showing us the way ahead. Thank you very much. Actually, the present pandemic has posed a dual challenge for the body and the mind. Psychosocial health effects of COVID-19 remain unseen and I'm sure are going to last longer than the physical threats. In India, our challenge has been huge. You see, this is also due to our social settings, our dense living settings, and the cordial and social gatherings that we are used to, the physical meetings and the celebrations. India is actually nation of festivals. We are unable to celebrate. We are unable to actually get together because we do have to observe physical and social distancing, not only for ourselves, but also to keep our loved ones safe. And this all has led to stress and anxiety. Stigma and fake news also has actually contributed to people feeling very anxious and also very stressful. There have been in the recent past, suicides, I think out of bewilderment and also out of not realizing and not being able to reach out physically to their loved ones. So this webinar is very timely. I would like to also say that we have in the ministry recognized the need to set up special resources for addressing issues of stress, anxiety, and mental health. It's a fact that our own mental health survey of 15 and 16, 2015-16 showed that there is prevalence of mental health issues of varying degree. I mean, it's not not all are very severe, and 150 million Indians need active mental health care intervention, but very fewer than 30 million are seeking it. We are actually quite hesitant to talk about these issues. I wish we could discuss our stress, our anxiety, our depression with our loved ones, just as we discussed our diabetes, our hypertension, or our other diseases. So I think time has come for India also to acknowledge and talk about mental health. And I think I must thank NIMHANS under the leadership of Dr. Gangadhar that we have actually put in a lot of effort. There is a national mental health helpline run by NIMHANS, which is then onboarded by various states in their vernacular languages. This helpline has been widely publicized. We have a separate section on behavioral health and psychosocial resources on our website. Our website has viewership running into millions, so that is also very helpful. We have videos and small clips helping people to cope to see those even if they are in isolation, so that it can help them cope with stress. We have actually there is a dedicated site called covidwarrior.nic.in, which actually has about 116,000 psychology and social welfare professionals, which are line listed as per districts. And this has been done, this aggregation of human resource has been done so that at the disaggregated level, the concerned administrators, the concerned doctors, the concerned institutions can avail of the services of these very efficient and I would say precious resource to deploy them in settings where they will be useful and they will be helpful. And we've had nearly 2.58 million viewers on webinar and courses related to COVID and mental health together. But I'm saying all this is just to tell the participants and our experts that what we are doing is only a drop in the ocean. We need further guidance on how we could take further and help and reach out to people. We are especially, we want to start a communication series engaging specialists, experts, and achievers from various walks of life to give educational and motivational talks so that people can be reached far and wide. And we would like to translate this into vernacular languages because India is so diverse. So I would request this webinar to also address how you could help us, how we could reach out to people. And I close thanking our experts for participating and also thanking NIMHANS for taking this initiative, this very, very important initiative. And we must have many such webinars in future also. Thank you.
Thank you, ma'am, for your enlightening words. Before we start off with the sessions, we have a few housekeeping announcements. We want this webinar to be as interactive as possible. So please feel free to type your questions on the chat box, which has been made available to you on the webinar platform and through the YouTube live streaming, the link of which has been already circulated. Since we have several speakers, so please type the name of the speaker you want the question to be addressed to. Kindly keep your microphones muted during the speeches, and all the questions will be taken up at the end of the final presentation. So with this, I now request Dr. Neha Kulkarni to introduce us to our first speaker.
Good evening, everyone. Our first speaker of the day being Dr. Lakshmi Yatham, who's the professor and head, Department of Psychiatry, and Director at Institute of Mental Health, University of British Columbia, Canada. He's the President of World Federation of Societies for Biological Psychiatry, Editor-in-Chief of Canadian Journal of Psychiatry. His areas of interest being bipolar disorder, with more than 330 publications in the field. His accolades include Morgan Score Award, Gerald Clerman Award, and Colvin Prize for bipolar mood disorder research. He's one of the top 1% of highly cited researchers. I now invite Professor Lakshmi Yatham to deliver his talk on addressing mental health needs of the public. The platform is yours, sir.
Maybe click the presentation mode.
Yeah.
Okay, perfect. Thanks very much. First of all, let me say it is such a delight to see so many colleagues. And I want to thank for the opportunity to share what we have learned about the mental health impact of COVID-19 with all of you. So I think this slide has been circulating around for quite some time, and I'm fairly sure that many of you will have seen this, and you'll see this in Keshavan's presentation as well. So what this shows is what typically happens during a pandemic, and that is in the set of earlier stages, the acute care beds are overstretched, and then around that time or slightly after, mental health problems are sort of begin to emerge and then steadily increase with time. Now, of course, with COVID-19, this pandemic is probably something that's none of us have ever seen, meaning that there's probably nothing like this that we witnessed in our lifetime so far. And so as we look to the future, I think there are a lot of uncertainties in terms of how this is going to evolve. In looking at some of the numbers this morning, I think so far something like 13.5 million people have been affected and close to 600,000 people have died so far. So I think one thing that is probably very clear is that there is going to be a significant mental health impact or aftermath, and some might even call it a mental health pandemic, so to speak. How bad that's going to be is anyone's guess at this point in time. Let's go to the next slide, please. So there are many factors that likely will contribute to the mental health impact of this pandemic. And I've just picked about 5 of those. The first one being, and probably one of the most important ones, is fear of contracting the disease and also passing the disease on to some of the loved ones. And this is obviously a major source of stress. And I think to mitigate the risk of spread, as we all know, many countries around the world had implemented lockdowns. Some of those have been lifted, and some of the countries have begun to re-implement these lockdowns again. And I think one of the consequences of these lockdowns is that they tend to disrupt our social rhythms, our daily routines. And we know that our biological clocks are entrained by these social rhythms. And when those biological clocks are disturbed, they tend to lead to depressive symptoms. Can we go to the next slide, please? So this is a study we did very recently, just trying to understand that relationship between social rhythm irregularities and stress and depressive symptoms. And what we found was that there was a significant negative correlation between stress and social rhythm irregularity. And equally importantly, we found in our recent study that there is a clear relationship between development of depressive symptoms and social rhythm irregularity. So clearly, disturbance in these social routines seem to have a significant negative impact on mental health. Let's go to the next slide, please. There are obviously other consequences of this pandemic. Economic impact is another massive one, with job losses and businesses being shut down, with service industry affected most significantly. Oh, go back to the previous slide. So that's another significant risk factor. Traumatic experiences of witnessing relatives being admitted to hospitals, being on ventilators, relatives, friends, acquaintances dying, obviously are major stressful factors. And lastly, we also know the virus itself seems to affect the body in many different ways, particularly its impact on the immune system. And also, we know that it enters the body through the ACE2 receptors, and these are overexpressed in some of the areas of the brain that are intimately involved in emergence of the mental health symptoms. So areas such as hippocampus, amygdala, and some of the monoaminergic nuclei regions as well. So there are many reasons as to why this pandemic might have a significant impact on mental health. Let's go to the next slide, please. So I think how these factors impact really depends on which group one might belong to. So for example, for someone that's in the front line as a healthcare worker, fear of contracting the disease and spreading that to loved ones is a massive risk factor. And of course, those with the pre-existing mental health conditions, many of these tend to operate, and there are many others as well. Let's go to the next slide, please. Now, the challenge, though, is that we all do believe, for the reasons that I have outlined, that this pandemic is going to have a significant impact on mental health. But unfortunately, the data so far, in terms of addressing what the impact is of very poor quality. So if one looks at what's been published in various journals, many of them are opinion pieces with not much data. And most of the data that's been collected, still go back, please. Previous slide. Most of the data that's been collected is sort of based on surveys, and many of these surveys have not used the sort of a best methodological strategies to estimate the impact. So there are numerous methodological problems with these studies. Let's go to the next slide. So this is a survey that was done in Canada, and again, these surveys are done on a weekly basis, and depending upon when the results come out, the sort of percentages tend to vary. But I think most of these surveys tend to look at some of the common problems such as anxiety, depression, substance use, and as you can see, approximately a quarter of the population seem to endorse each of those things. Let's go to the next slide, please. So what about the studies that have been done? And I think most of the data that has been published comes from some of the studies that have been done in China. And this is a systematic review which included about 12 studies with about 27,000 people. And this systematic review suggests that about a quarter of population are endorsing anxiety symptoms, and approximately similar number endorsing depressive symptoms and also substance use as well. Now, don't forget that these results are based on very sort of blunt instruments such as PHQ-9 or GAD-7 or GAD-2, things like that. Let's go to the next slide. So this is another more systematic review with more patients or more respondents included in these studies. And again, the numbers seem to be fairly similar, ranging from a quarter to a third of a population endorsing stress or anxiety and depression. So I think it's fairly clear about a third or a quarter of the population have these symptoms. What's unclear is how many of these people actually meet the criteria for some of the DSM-5 or ICD disorders, and that research is still not there, not out there as yet. Let's go to the next slide, please. So this is a study that was done at UBC, again, looking at about 3,000 people, and these people have been asked to complete questionnaires on a weekly basis, and this is sort of methodology everybody seems to be using these days. And as with the other surveys and studies, the UBC study also found fairly high incidence of depression and anxiety. And in this particular study, our colleagues looked at what are some of the predictors of increase in depressive symptoms in the respondents. And they found, again, not surprisingly, low income, difficulties with school and work, social isolation, concerns about getting basic necessities. So some of the risk factors that we talked about seem to be the ones that seem to predict some of these mental health symptoms. Let's go to the next slide, please. So if a quarter to third of population are likely to be affected by this pandemic in terms of the mental health concerns, the question is, how do we address the needs of these populations? So this is an editorial that we published in the Canadian Journal of Psychiatry, where we address in detail what are some of the strategies that one might use to address the needs of those four groups that I've talked about earlier on, and that is, if you have someone in the general population that has mental health issues, what are some of the main strategies one might employ versus someone with a pre-existing mental health conditions or frontline health workers or those that had COVID-19. And I'll talk about some of these in terms of what we've done in managing this issue within BC. So let's go to the next slide, please. So what we saw with this pandemic, and I think like everyone else, we were, from the mental health perspective anyway, we were expecting the worst. But luckily enough in BC, our chief medical officer has managed the pandemic quite well in collaboration with our health authorities. So we all worked together. So during the acute phase, at least within BC, although we were expecting the worst, even from the medical perspective, our system was not stretched at all. And in total, we've only had about 3,000 cases of COVID-19 within the province of British Columbia. But from the mental health perspective, we were also expecting a significant surge in demand. And so we had pre-planned by preparing for the worst case scenario in terms of creating COVID cohort units and redesigning our mental health services. But to our surprise, what we actually found in the initial days at least was that there was a 40% reduction in bed occupancy. So number of our mental health beds were empty. And as the pandemic evolved, what we found was that many patients were afraid to come into the hospital because they were concerned about getting contracted with the COVID-19. So that was one of the reasons for people sort of shying away from the hospital in the initial days. Although that has changed since then. Now we're back to 105% bed occupancy, which sort of goes with the expected increase in mental health problems that most people have predicted. Again, in the initial days of pandemic, our outpatient activity reduced by 50%, and we swiftly switched to our transition to virtual care, with 95% of our outpatient activity was done through the virtual strategies using Zoom and many of the other strategies. The COVID cohort units that we had created, most of them were empty, so we finally end up switching to one unit where most of our patients were admitted. So we've been incredibly lucky in BC in managing this exceptionally well. Let's go to the next slide, please. So what we had done, apart from just addressing the hospital situation, as I mentioned earlier, one of the major reasons as to why we've been so successful in BC, I think had to do with the consistent messaging from our chief medical officer and also chief medical officer working with health authorities. What one doesn't want to see is what Trump is doing, minimizing the problem and giving messages that are inconsistent and clearly erroneous. So that's obviously what's causing huge challenges in the US. We created a crisis line. The volumes for our crisis line went up by something like 400%, and those continue to be high. But also our government gave about $5 million to beef up our virtual mental health system capacity in partnership with the Canadian Mental Health Association, so that anyone with depression, anxiety symptoms can access online CBT with coaching support, and that has had a huge impact. We are working on redesigning the social rhythm therapy based on some of the research that we've conducted, and we're hoping that will be ready for deployment in the near future. We've also made sure that some of the frontline healthcare workers' needs were addressed. So within each of our health authorities, we established teams that were available to provide psychological debriefing for our frontline healthcare workers. And for our physicians, we worked with the Doctors of BC to set up a virtual mental health care system so that any physician that has had any mental health issues can access these services quite rapidly. So by providing access to a number of these psychological supports, we were able to address the mental health needs of the frontline healthcare workers and also our general public quite rapidly. And all of these have had significant impact. And finally, I think some of you may have heard about what the governments in each of our provinces and the Canadian government has done in supporting the financial impact of this COVID-19 by providing wage subsidies to people and also providing business loans to businesses to support their activities. So I think we've used sort of a multi-pronged strategies to some extent, I would say, to mute the mental health impact of the COVID-19 so far. But just looking at what's happening in the rest of the world, we're not done with it. And worst is yet to come. We are preparing for the second and the subsequent waves. Just go to the next slide, please. And that's going to be my last slide. So as you heard, I think one of the major strategies that's been incredibly helpful is the transition to that virtual care strategy. And our government has recognized that, and our Prime Minister has announced $250 million to further refine our virtual care strategy. So this is an editorial that we published, basically pleading to our Prime Minister that this is great that you're investing this much money, but let's just make sure that it is invested in right areas. Although transition to virtual care has been incredibly swift, there are a number of issues with the virtual care strategies, including things like privacy. So all of those issues are addressed in this editorial. So I'm going to stop there, and thank you very much for your attention.
Thank you, sir, for elucidating the importance of mental health needs of the public. I now request Dr. Pratik Varshne to introduce us to our second speaker.
Thank you, Dr. Bhavika. It is an honor for me to be introducing the next speaker, Professor Dinesh Bhugra. To his various credentials, there is being the former president of the World Psychiatric Association, the Royal College of Psychiatrists, and the British Medical Association. Currently, he's the Emeritus Professor of Mental Health and Cultural Diversity at King's College London. His areas of interest include cultural and social aspects of mental health, including social anthropology and community psychiatry, and history of medicine and policy making. His interest has led to research and publication of more than 450 articles in national and international journals of repute. He has authored more than 40 books, which have been translated into various languages, including Japanese and Chinese. In 2019, he was awarded the Book of the Year for his textbook of public mental health. For his research and work, he has been the recipient of many honorable awards, which include the coveted Commander of British Empire in 2012, the Lifetime Achievement Award from the AFPA, the Honoris Causa from National University of Paraguay, and the prestigious Presidential Medal from the President of Indian Psychiatric Society. I would now like to invite Dr. Professor Bhugra to deliver his speech on mental health of the underprivileged during COVID-19.
Right, while the slides are loading, yeah. Okay. Can everybody see that?
Yes, sir.
Okay, and right. It's a great privilege to be sharing the platform with stalwarts of psychiatry, and particularly in a sort of global pandemic. And I think it is absolutely critical that we learn from each other and we have a global response rather than each country thinking as if the virus knows walls and knows needs visas to cross countries. What I'm going to do is, right, bear with me. I'm going to sort of present some findings from a major report that the Public Health England had done on underprivileged populations in the UK. And you may have seen the headlines that South Asians are much more likely to have died from COVID, both as members of the National Health Service and the frontline staff, but also in the general population. And just to remind us that underprivileged populations generally mean women, children, elderly, minority racial groups, ethnic minorities, LGBT populations, people those who are poor, unemployed, living in overcrowded conditions. And I think the challenge does remain about definitions and heterogeneity of groups. I'm going to focus on race, gender, and poverty. I haven't got data on LGBT populations. I'm not going to be covering that. But again, I'm not going to define race and ethnicity. I think people are aware of that. And so it's basically the things that we need to be bearing in mind, that racial groups are not genetically discrete. Often they're not reliably measured, and certainly they're not scientifically very meaningful. But these kind of feed into racism, and particularly in, you would have been aware of the tragic murder of George Floyd in Minneapolis and subsequent campaign around the globe on Black Lives Matter. And it is also worth bearing in mind that there is a difference between race and culture, and they carry different meanings. And we have known for a very long time, certainly since the 1960s, that the rates of various psychiatric disorders are higher in some Black, Asian, minority ethnic groups. We know that schizophrenia is much higher in African Caribbeans. Depression is much higher in South Asians as a deliberate self-harm. And particularly Bangladeshi and Pakistani populations in the UK have shown much higher rates of depression. And in the minority ethnic groups, there is also a challenge that we do not know enough about East European groups. And these variations have been attributed to a number of factors, such as genetic, and then, about 30 years ago, there was a theory that it was all about winter births. Then it was about obstetric complications, particularly among African Caribbeans. And there have been studies which have argued that there are social and psychological factors, whether these are related to structural racism or not. But what that has meant is that quite often this leads to misdiagnosis, overdiagnosis, cultural conflict, etc. And we know that the help seeking is delayed in many ethnic groups because A, they're not aware of where to go, what to do. They may have very different models of explanation of their distress, so they may seek help elsewhere. And in the UK, certainly till a few years ago, every summer, there would be Hakims and Vads coming from India to places where there are large South Asian populations. So it's a very different issue related to help seeking. And we know that South Asian populations particularly have much higher rates of diabetes mellitus, of hypertension, higher levels of obesity, and other chronic physical illnesses such as osteoarthritis, arthritis, chronic obstructive pulmonary disease. And I know that Black Lives Matters campaign has shown that there is a challenge in terms of structural racism in the society. And it is quite evident that even when within the lockdown, quite often Black drivers or people of color who were out were much more likely to have been stopped by the police. And we know that from the National Health Service that they're less likely to be listened to for whistleblowing, and they're more likely to be low-paid frontline and care home staff, particularly from the Philippines and East European. And they've had more problems in accessing personal protective equipment. Just to illustrate that the death rates due to COVID among Asians and Asian British have been 1.5 times those of white population. Among Blacks, they've been 1.7, a mixed ethnicity 1.6, and others non-white is 1.3. And risk of dying following a positive test is 2 times higher for the Bangladeshi group, 1.4 times for the Pakistani group, and 1.3 times higher for the Chinese group. And these findings are from the Public Health England report. And as I said, that they've been consistently higher rates for other ethnic groups, sometimes almost equal as in other Asian or in Black Caribbean, particularly risk of dying, which is higher for the Indian group. But if you have diabetes type 1 and your HbA1c is equal to or less than 58 millimoles in the previous year, your risk of dying is twice. But if it is more than 58, then it goes up to nearly 3 times. And similar differences in diabetes type 2. And interestingly, there's been a scale where they have looked at what they describe as COVID age, which summarizes vulnerability for combination of risk factors, and they weigh each risk factor. And because women are generally said to be more protected, their COVID age is lower. For example, healthy white women age 40 will have a COVID age of 32, whereas white men aged 45 with BMI of 36 and severe asthma will have a COVID age of 45, 5 years for BMI 36 and 4 years for severe asthma, therefore giving an overall age of 54. And an Asian woman age 50 with diabetes type 2, 2 HbA1c over 58 has COVID age of 50 minus 8 because she's a woman, plus 5 plus 10. So her COVID age is 57. So added years of age for Asians or Asian British are 4 years, for blacks is 6, for mixed ethnicity is 5, and for others non-white is 3. So you can see there's a moderately robust or provisional evidence for that. So similarly, due to BMI, if your BMI is between 30 to 34.9, it adds 4 years to your life. Between 35 and 39.9, it adds 5 years. And if it's over 40, it adds 10 years. And similarly, the moderately robust data, diabetes type 1 adds years to your COVID life. Similarly, with other chronic conditions, heart failure, its chances of dying of COVID are 2.3 times. Years added 9. Similarly, in cerebrovascular disease, and the evidence for these is moderately robust. And it is, again, I mean, if you look at organ transplant, if you've had an organ transplant, then your chances of dying from COVID is 4.3 times higher, and it adds 16 years to your COVID life. So again, I'm not going to go through that, but it's consistent. The findings released by Public Health England about 2 weeks ago suggest that risk of dying following testing positive 70 times higher in people 80 years or older than those under 40, higher in males, higher in those living in more deprived areas, and in Black, Asian, and minority ethnic groups, even when it's adjusted for age, sex, deprivation, etc. So ethnicity and income inequality are independently associated with COVID-19 mortality. And as Lakshmi has already mentioned, I'm not going to go through that. But it's also worth bearing in mind that BME populations in the UK work in occupations which place them at increased exposure. As I said, quite a lot of them had been working in social care homes. A lot of them had been frontline NHS staff, but also driving buses. There was a rather tragic incident of a bus driver who had been spat on by somebody who had COVID, dying of COVID subsequently. And BME individuals use public transport to travel to work. And there are, obviously, long-standing inequalities, and Public Health England did a survey, qualitative survey with about 4,000 qualitative interviews looking at the risk to exposure and risk of complications and dying from COVID-19. And it is important to sort of recognize that minority populations and underprivileged groups also have much more issues related to diet, poor diet, smoking, infectious diseases, etc. Although women are less likely to be infected or develop COVID, but there's clear evidence that violence against women and girls has increased exponentially. Over 243 million women and girls have been subjected to sexual and physical violence in the previous 12 months. This is general intimate partner violence. And there's been an increase in France, for example, by 30% since the lockdown. In Argentina, by 25%. Similar figures in Cyprus, Singapore, Canada, Germany, and UK. There's been a rise of domestic violence with increased demands for emergency shelters. And it is also that women quite often are in insecure jobs, so they're losing their jobs, and economic pressures create additional problems. And we know from previous outbreaks that once the pandemic is over, men's economic activity may return to pre-crisis levels, but impact on women's economic security tends to last much longer. So the global recession that will occur is likely to contribute to a dip in women's income and unpaid care work, and pushing more women into poverty. So the key messages are that we need to be aware of the long-standing impact of social and economic inequalities, and pandemic has just brought this to the forefront. Underprivileged groups are more likely to be exposed to risk, have higher risk of complications, and this may be related to issues to stigma, discrimination, racism, lack of trust, etc. So just to conclude that in underprivileged groups suffer more disproportionately. They also have higher levels of comorbidities, and what we need to be looking at is both sort of structural changes. This is not a pandemic which is affecting countries in isolation. This is a global issue which needs global solutions and global work to get to the next stage. Once again, thank you very much for inviting me, and thanks very much for listening. Happy to take questions.
Thank you, sir, for highlighting the mental health concerns of the vulnerable sections of our society. I request Dr. Nivedita Sudhir to introduce us to our third speaker.
Thank you, Bhavika. It is my privilege to introduce to you our next speaker, Professor B.N. Gangadhar, who is a senior professor of psychiatry and the current director of NIMHANS. He was awarded the Padma Shri, one of the highest civilian honors by the Government of India for the year 2020. He also has a DSc from the Swami Vivekananda Yoga Anusadhana Samsthana for research work in yoga and mental health. And he is a fellow of the National Academy of Medical Sciences. His areas of interest include schizophrenia, addiction medicine, electroconvulsive therapy, yoga and mental health, and community mental health. His research work includes over 350 publications in both national as well as international journals. And he's the recipient of many honorable awards: the Sir C.V. Raman Award, the Doctor's Day Award from the Government of Karnataka, and many others. His talk today is on preventing the comorbid disaster. And I now invite Professor Gangadhar to commence his talk.
Yeah. Are my slides visible?
Yes, sir.
Yeah, wonderful. Thanks, Pratima, for making a wonderful team to share our observations on concerns related to mental health during COVID. What I will share in the coming maybe 10 minutes or so would be our work related to how we face the challenges of managing mental health in NIMHANS and also in the country at large. What are the contributions that we made and how it has shown results. Essentially, we see these challenges emerging from the COVID scenario, and we had the opportunities, we converted them into opportunities, and this is precisely what I'm going to share. This is something that I'll be presenting as a representative from the entire mental health division of NIMHANS. There are several people who contributed to this, starting from the Department of Psychiatry, Psychology, Social Work, Mental Health Education, and Nursing. So many people contributed to this. This is what I'm going to be presenting as a summary of what we did in clinical services, what we contributed from the community mental health services. Dr. Mohan has been the person who laid the foundation for community mental health services way back almost 3 decades ago. Sir, you're going to witness some of the developments that we're going to be seeing here. Before I continue with my talk, I got a message from the secretary. She may probably be leaving at any time because of her other commitments. Both the secretary and Srimati Preeti Sudan and our economic advisor, Sri Nilambu may be leaving at any moment halfway through. They said they have another appointment to meet. Given the COVID crisis all over the country, it's well expected. Thank you, madam. Thank you, Nilambu for being there. Thank both of you for giving an inspiring introduction and releasing our Samatvam magazine. I'll continue with my talk. We would, of course, miss you in the later part of question and answer, though. So coming back to my talk, clinical services, community mental health services, we did several training and capacity building throughout the country, and we produced many information, education, communication, brochures, slides, etc. I'll come to that later. Coming to clinical services, what we did, there are 3 areas where we contributed. One of them was, which is the brainchild of Dr. Pratima, continuum of care. We closed down the outpatient services once the lockdown was announced in March, end of March. We knew that people wouldn't have facilities to travel, and also OPD crowds used to be very huge, and social distance would be a myth. And put together, we thought it's a good idea to close the outpatient services. Government also gave an advisory that people should utilize hospitals largely for emergency services. So we closed the outpatient, but our concern for our patients in psychiatry made us go back to their case files. In all places where the cell phone number was registered, we made them, we called them up and facilitated them getting a consultation. And where possible, we also liaised with the district mental health program in Karnataka, and also the Bangalore metropolitan hospitals, where these people can be sent to receive their medicines where required, or consultations near their house through these services. Apart from this, the telemedicine services, I must say regarding telemedicine, the very timely intervention by the Medical Council of India, who gave the telemedicine guidelines. A ordinance was made and order was made, and so telemedicine became a very legitimate business in our clinical practice. So following that, NIMHANS also produced the telemedicine guidelines for mental health psychiatrists in particular. And thanks to the telemedicine group at NIMHANS and also the Indian Psychiatric Society, the national body, together this thing was released. And so for mental health care, telemedicine is now a legitimate activity. So we allowed face-to-face interviews in these telemedicine services, also generate an electronic prescription. We had some challenges here. Again, thanks to COVID, we could push this issue of letting them prescribe benzodiazepines. We allowed one benzodiazepine to be prescribed to the telemedicine services. Clonazepam, a lot of people during the COVID had anxiety disorder. Clonazepam also helped many neurologists because they were using this for prescribing to patients with epilepsy. And we also were able to introduce methylphenidate, which was again a very useful medicine in patients with hyperkinetic disorder. We had this opportunity to introduce the interactive voice response system for people to telephone, take an appointment, and then come. Something that we would never have imagined before this COVID started. This was a challenge that people couldn't come directly and wait in the queues, crowding. To overcome this, we introduced this. This gave us an opportunity to convert outpatient services to an extent possible using the IVRS, although we still have to saturate this process and so that make everybody use this service. So together, these changes led to closer to about 20,000, although this 50,000 phone calls was a week back's number. We have made almost 20,000 phone calls, of which close to about 1,800 people benefited from free drugs. As you know, that a lot of people would get follow-up prescriptions as free dispensation at the NIMHANS counters since the OPD was closed, and thanks to the DMHP and the Bangalore Metropolitan Hospitals, we were able to deliver medicines to the Bangalore centers. 11 centers cooperated with us, and close to about 30 districts. All districts helped us in case we asked them to go to their nearest center. The district gave us the medicines from the district mental health program stocks. We were able to give a telemedicine services to 150 consultations. The interactive voice response system, although we had some hiccups to start with, but soon it picked up, and close to about 1,800 people called up and obtained appointments. These changes, in addition to that, OPD was transformed. In the period of COVID, we knew that the lockdown would be lifted and we would get back our crowd, etc., etc. So thanks to the hospital administration, which made larger waiting halls outside the building of the outpatient, and also decluttered the outpatients' waiting halls to be able to make people sit in a more distant way, to give a lot of space between them. Together, the work efficiency and the comfort levels in the outpatient largely increased. And we had done it during the period of lockdown, and thanks to all this preparation, following the lockdown, when we lifted the outpatient closure, we also got the outpatient activity back. The functioning was a lot smoother. The community mental health team did a wonderful job during this period. One of the activities was looking at the concerns of travelers who were quarantined, particularly those who are air travelers who are quarantined. Dr. Mohan was mentioned that he was quarantined for 2 weeks. I don't know whether he is going to accept what observations that I have had here from our colleagues in quarantined people. So the quarantined people were spoken to and were examined. Services were offered for counseling. Thanks to the Karnataka Health Department's mental health team, which actively worked with us. So what we had sources of distress, boredom, social isolation, concerns about their job, they're getting salaries, fear of infection. What if the test results going to be positive? Concerns of spreading infection to the family members, and largely, of course, stigma. So these are the symptoms which Lakshmi also mentioned. Close to about 20% of them have anxiety and depression symptoms, sleep symptoms, and even suicidal ideations were present in this population. 1,600 phone calls were made to these people under quarantine. With these questions, we had this data analyzed. As you might have read in the newspapers and other media, concerns about migrant workers during the lockdown period was enormous. Thanks to several health departments, several state and central administrative bodies, they handled the migrant workers' concerns quite well. Nonetheless, places where migrant workers were camped, we had an opportunity to go meet them, educate them, present some posters explaining to them about the illness, not to have concern, but to be careful. And these things led us to develop a small video clipping and also an advisory as to how we need to work with these migrant workers with respect to mental health services. We had help from the Bangalore Metropolitan Group, who had their health workers come along with us in the part of education and facilitating these things. So we had about 5,000 odd migrants assessed, and we visited as many as about 140 sites where migrants were located, some even in NIMHANS campus. Some of the migrant workers were doing a huge construction. The construction had stopped, the contractor had to withhold all activities, and their concerns also were examined. 13 people had pre-existing mental illness of severe nature, new onset mental illness in about 5 people. We referred about 15 of them to different hospitals for further management. They had flagged several concerns, uncertainty about how long would this lockdown go on, wanted to go back to their families, fear of being abandoned by their employers. Unattended, some of them were carrying some of the women who were pregnant, and they were concerned what will happen. Substance use related issues also of concern. What if I am not going to get alcohol in the next few days? I'm going to have withdrawal. I've had this problem. So these are the concerns that they express, and thanks to the community mental health team and also the Karnataka State Government Health Department, which made this highlighted, and all other workers who went on to now work with the migrant workers took these observations and helped the subjects by appropriate counseling. We also launched a helpline. The moment the lockdown started, we anticipated a disaster-like situation, and people would be very concerned. Public, both those who are infected and those who are not infected, would have a lot of concerns. So we set up a helpline, a toll-free helpline for people to seek any counseling. And thanks to the Ministry of Health, they said this should be a pan-national activity. So they requested us to engage as many mental health professionals as possible all over the country. And this was possible thanks to the Central Institute of Psychiatry and also the Tejpur Institute of Psychiatry. They participated. And also in many states, people came forward, as many as 14 vernacular languages from 16 different states, about 250 plus mental health professionals were able to give a helping hand. We were available. The lines could go to them. 3 lakh calls came, and close to over 50,000 calls were related to mental health services. Again, thanks to the Secretary of Health, Government of India, we were asked to also dedicate a separate line for helping the healthcare workers and their mental health concerns. And to these people, highly trained professionals from mental health, from the Department of Social Work, Psychology, or Psychiatry, from NIMHANS were available to help them. I do not have the exact number of people who sought help for mental health conditions from the group of the healthcare providers, who were not just the COVID warriors, but many other groups of people. We did several their stress-related concerns. Clinical psychology, psychiatric social work. So we had close to 30,000 people benefiting from this. I'm just making a list of activities that the Department of Psychiatry has done. The slides will be available on the net. I'm not going to details of these things. We trained psychiatrists in many states. We also trained lay counselors. We trained obstetricians for concerns related to postpartum or newly perinatal period, when the mothers had questions like, can I feed my child if I develop COVID? Things such as that. So obstetricians were also trained to allay their concern. Registered medical practitioners, psychiatrists. We also trained psychiatrists using a CME program on how to use telemedicine in psychiatry. This is a list that we did through this telemedicine services. And we also have a very, very vibrant NIMHANS Digital Academy, which also jumped into the fray, making this training to several groups of people on just mental health, the substance abuse disorders, and the Health University of Karnataka, Rajiv Gandhi Health University, actually participated with us in training many people on issues related to mental health and other directly public health importance in COVID. They used our platform of NIMHANS Digital Academy to train physicians, nurses, health workers all over the state. The Child and Adolescent Psychiatry also has plunged into this. The National Commission for Protection of Child Rights realized that child abuse was a concern, and a large project has been given to the Department of Child and Adolescent Psychiatry, NIMHANS. Dr. Shekhar Sheshadri is running this project, and this is now going to address these concerns of children, whether COVID or no COVID. I'm sure this program will be very helpful. The Department of Clinical Psychology did some unique activities, how to train psychologists very efficient in terms of telephone counseling. So they did a training program for people, psychologists, up to about 815 number. They also set up a portal on which people can discuss mental health concerns, share questions, get some answers. Answers are usually written by clinical psychologists or psychiatrists who would put the appropriate answer. Many questions were common, and close to about 150 questions for which answers have been generated. As many as about 35 answers which are common to these questions have been generated and has been put on this portal. The Department of Psychiatric Social Work, which also heads the Center for Disaster Management and Psychosocial Support, again did several programs for law professionals, police officers, and many college teachers and school teachers. And these were very well received, and many teachers participated and many police workers participated in this program. And in fact, the Karnataka government for the Bangalore City Police have asked us to conduct some programs, how to manage stress during the COVID situation. And this again has received a lot of interest. Lastly, before I conclude, we produced a host of information, education, communication material, pamphlets, videos, posters, newspaper articles. As many as about 100 newspaper articles came from the group of behavioral sciences, psychiatrists, psychologists, social workers, on varied topics related to COVID and mental health. Online blogs, publications, scientific publications also came. 22 publications have come in this period. Some as letters, some as opinion papers, and some are data papers. We also produce some short messaging services, small statements or advisories which will go as a SMS, as part of general public awareness. Thanks to the health department, many of these they also reviewed, did some tweaking, and a host of them are already on the Government of India Health Department's website. This is something that we will all boast for having contributed to the national activity in mitigating mental health stress, COVID-related mental health complications or comorbidity in COVID. Lastly, while we were doing many of these activities, we thought from week to week, we compiled all activities and published. 12 issues have come. The last issue was released a month later. Now the frequency of releasing these bulletins is once in 4 weeks. And this has attracted a lot of people, as many as 12 pages of this and 12 issues having come, compiles all the work that we have done till now. And of course, month to month, we are going to be updating this work as well. So I think I'll stop here. I must thank not just one department, but all the departments. There are many groups which are working, particularly the medical superintendents, present and the past medical superintendent who contributed enormously in developing these activities. The health education department, which made all the education material, and other academic departments which participated in many of these training programs. I must thank all of them. And of course, thanks also to the ministry, which was continuously motivating us and seeking demands, which made us produce all these activities. We recently completed a manual of how to address mental health concerns in mental hospitals, other mental health establishments, and psychiatric patients in general during the COVID period, when they're infected, when they're not infected, other challenges like hospitals being closed, OPDs being closed in some places, and people who are homeless, mentally ill, who are wandering. In all these situations, how COVID concerns can also be addressed, and COVID individuals' mental health concerns can be addressed. A manual has been released. A few weeks earlier, we also released a manual on mental health concerns in those who are healthcare workers. How do we address them, and how to manualize the whole services for them? So these are the activities that we have done. I thank again Pratima and team for letting me come over here. As a director of NIMHANS, I also thank all the esteemed speakers who have come in. I may not have the opportunity to thank you all at the end of this lecture. I thank all of you, and I see close to over 200 have logged in now, and about 30 to 40 have come in and gone. Naveen will tell us how many actually viewed the live YouTube process on this as well. Thanks once again. I leave to the organizers to take the mic.
Thank you, sir, for this engaging talk on how technology has assisted in continuity of care for our patients in psychiatry and measures taken to manage the new onset symptoms. I now request Dr. Pavitra to introduce us to our fourth speaker.
It's my privilege and pleasure to introduce Professor Mohan K. Isaac. He is a former professor and head of Department of Psychiatry at NIMHANS. He is a past president of the Medico-Pastoral Association in Bangalore and the Society for Community Health Awareness, Research and Action India. He is currently working as professor in School of Psychiatry and Clinical Neurosciences in University of Western Australia. His areas of interest include community mental health, public health, mental health in rural population, epidemiology, suicide, psychopathology, and somatoform disorders. He has served as consultant and advisor with World Health Organization in numerous occasions. He has got more than 175 publications in both national and international journals. He has been awarded DLN Murthy Rao Oration Award of the Indian Psychiatry Society. Now I invite Professor Mohan K. Isaac to deliver his talk on practicing psychiatry post-pandemic. Welcome, sir.
Thank you very much. Thank you very much, Pavitra, for that very kind introduction. It was I was really delighted to hear Professor Gangadhar's presentation about the contributions of NIMHANS. Earlier, of course, I listened to the Health Secretary saying that the Government of India is depending on NIMHANS for the major, contributions in the field of mental health, even not only now, but in the months and years to come. So in a short period, I think you have given tremendous leadership to a lot of activities by various people in different departments. And as an old student and old faculty of NIMHANS, I'm indeed proud to hear all these contributions. Now let me begin my presentation. Okay. So I want to express my gratitude to the NIMHANS organizers for organizing this kind of a webinar, which Dr. Gangadhar said, all the faculty, the visiting faculty have come together for the first time. But more importantly, I want to thank them because Naveen, the key organizer, asked me to talk about what happens after the pandemic, practicing psychiatry post-pandemic. This gave me an opportunity for some future gazing. And that is what I hope to do with all the participants who are now logged in. When you make speculations, you could be right. You can, of course, based on a lot of information that you have already, you can make speculations. But we have already heard from the Health Secretary during her inaugural speech. She said that the psychosocial problems are invisible. They are already there. But she already made a prediction. They are going to stay with us for a very, very long time. Now, Lakshmi in his presentation said that, we don't know yet how the pandemic is evolving. We are still in the midst of it, very much in the thick of it. For example, today, in India, we covered a major milestone. We covered 1 million cases. Of course, it was a gradual increase, but then now in the past few days, it has been very rapid. And in the United States, which is, one of the richest country, which spends for healthcare in terms of proportion of GDP, one of the highest in the world, about 17% of the GDP. They also created a record today for the total number of infections per day. It crossed 77,200 plus. So we are still in the midst of the pandemic. And when you talk about post-pandemic, you can only future gaze and make speculations. And that is what I'm going to do. What I do is raise numerous questions and try to answer them as I go along. I promise you I will not take more than 10 or 12 minutes because there should be some time for discussion. And of course, we are waiting to listen to Dr. Keshavan, who has already written about the research and he has excellent ideas about research. So I would try and stop in about 10 to 12 minutes. So psychiatry has weathered lot of upheavals. Even if you look at the last 1 century, we have had major problems. Is this pandemic the most disruptive? I think there is a very wide belief that this has been the most destructive. Many people have written about it. In fact, Henry Nasrallah has written that this is the cataclysmic event which has changed everything in the world. So I would think that it is a pandemic that has been the most disruptive, and probably it is going to change the practice of psychiatry forever. In fact, Lakshmi indicated to that. He said how swiftly they in Canada have moved to the digital mental health platform and virtual care. I'll come to that later on. Is the pandemic a much needed wake-up call for psychiatry? The optimist in me made me think that, okay, this is a very good way, because I'm going to later talk about various fault lines which have been there, not post-pandemic, but pre-pandemic. When you talk about post-pandemic, we need to look into pre-pandemic period and what have been the various fault lines. So I would think that all of us, all organizations, all mental health professionals should consider this as a wake-up call for psychiatry. But what would be the outcome? Will there be better funding? Will there be greater awareness? I will touch upon that as I go along. Any lessons from the past? Of course, in the very next slide, I'll touch upon that. What does post-pandemic mean? I've already mentioned that we still don't know. But again, from the past, I'll give you some indications about when we can refer to a post-pandemic period. How do we know about the pandemic? How do we know that the pandemic is over? I think we are far away from that point, so we don't have to worry so much now itself because we are in the thick of the pandemic now. fault lines in practice of psychiatry, I will tell you that. Okay, any lessons from the past? What has been widely talked about is the Spanish flu, more than 500 million infections, 5 million deaths. But what is important to note is that it came in 4 waves over about little over 2 years. So we are still in the thick of the very first phase. This is the first year, maybe about 5-6 months. Although it started in later part of 2019 in Wuhan in China, it didn't become a pandemic then. Although the spread may have begun, it was only from March, April that the borders have been shut and the quarantine and the many other things that we have been talking about started. So going by that, this is likely to go on for at least another year. I mean, if we are in the very first phase, in Australia, in Victoria at least, everybody thought that they had successfully flattened the curve. In Victoria particularly, now they are having the second wave. Again, the borders have been closed down. So maybe some countries are seeing the beginning of second wave. Europe, of course, it is settled down. In the United States, maybe New York is settled down, but other places are going up. So lessons from the past, it is too early to think of the post-pandemic period. I will not, of course, go on to the various other disruptive moments, because I do not want to take time on that, and people who are familiar with the history of psychiatry and how psychiatry has faced all these disruptions will know very well. The 2 world wars, but of course, the deinstitutionalization movement, we saw tens and thousands of people be discharged from mental hospitals in the United States, in UK, etc., and the problems which that caused, which we are even now facing after 30-40 years. People are talking about even now. I'll touch upon that. The Cold War, the collapse of the Soviet Union and communism, when alcoholism went up in the former Soviet bloc, suicide rates went up, fiscal health deteriorated. So we know that these kinds of major upheavals can have disastrous consequences, not only on healthcare, but mental health care. Now let me move on to the next one. What are the fault lines that I refer to? I don't have to highlight that, but since I've been asked to talk about psychiatry post-pandemic, I think we should look into the major fault lines that we have still not been able to deal with effectively all over the world. The huge treatment gap across the world. I would say across the world, even in advanced countries. If you look at the research data, you find that it is only a difference in the degree of the hugeness or the wideness of the treatment gap. Of course, in countries of Asia, such as India, other places, it is huge. But even in countries such as the United States, I mean, of course, Canada and Australia may be partial exceptions to this, but the huge treatment gap. Grossly inadequate resources, not only financial, but also human resources. The continuing universal stigma, which even the health secretary referred to in her speech. These are all fault lines that we need to be aware of as we plan for the post-pandemic area. The shameful neglect of persons with severe mental illness. Even in the rich countries, advanced countries with immense resources, this has been a big problem. Why? Because recently I read Alan Francis saying that tens of thousands of people with severe mental illnesses are dying in the United States because of the comorbidity. We listened to Dinesh talking about the comorbidity, the ethnicity, the long-standing economic situation, which have all been negatively affected people, the populations as well as people who suffer from COVID. The neglect of disadvantaged populations, the rural populations are vulnerable, the economic and social policies which have promoted inequity and inequality. I'm very confident to say that all over the world, at least in the last 20 years or so, the economic and social policies have only contributed to increasing inequities and inequalities. Ridiculous inadequacy of the number of psychiatric beds where people with serious mental disorders have been, in the next slide I'll show you, the homeless, mentally ill, a large number of people in jails in the United States and many other places with a diagnosis of mental illness, trans-institutionalization. All these have to be kept in mind as we, the point I'm making is that while we talk about psychiatric practice post-pandemic, we should be aware of the large fault lines which we have not been able to effectively deal with. This is a Fuller Torres famous book about the American psychosis. he recently, less than 6 months ago in October, giving the keynote address at the American Psychiatric Association of Institute of Psychiatric Services conference. He said, rarely have so many well-meaning people been so wrong. My generation made major mistakes in emptying the state hospitals without thinking about how to treat the seriously mentally ill in the community. It is up to the next generation to solve these problems. I'm only highlighting these so that we are aware of these issues as we plan for psychiatry and mental health care post-pandemic. This, the problem of long-standing inequities socially, economically, and their consequences on mental health has been highlighted by Dinesh in many of his slides. But I would, those of you who want to know more about it, it's not a psychiatrist, it's an economist, Joseph Stiglitz, who is a Nobel Prize winning economist who wrote several years ago, The Price of Inequality. And there are sections in this book about the mental health consequences, the social problems. And I think the COVID pandemic has only exposed these problems, because in all countries, including in India, today there is a CNN report, a very extensive report about how the poor, about the 60% of poor people in India are the worst victims of the pandemic and be closed down, etc. People, middle class, upper middle class, of course, they have their homes, they can sanitize, they have their maids to come and work, etc., etc. So the price of inequality, people who want to know more about it, the Oxford, they have looked at not just $2 a day, $3 a day, but people who are interested in knowing how inequality, how wide it is even in very advanced countries, including perhaps not in we initiated the WFPA Lancet Psychiatry, talking about the future of psychiatry. And again, I'm highlighting the point that psychiatry is not all very good. I mean, post-pandemic we can talk about, but we need to be aware of all these fault lines before we move into the future. Now, very quickly, what are the things that we have to be concerned about? I have already made this point that the pandemic will not pass quickly. We are already harnessing the potential of technology to provide more efficient and better care. The digital mental health care, and how swiftly we have moved to virtual care. I'm not going into the details of that. Lakshmi mentioned about that, but that is something which we have to focus much more on. While we consider this, we need to also acknowledge the fact that pandemics will be a part of our future. People have already talked about how are we going to deal with future pandemics. Okay, what are the major things that we need to deal with? It's already been referred to by my previous speakers. Already, Lakshmi talked about the current rates of anxiety, depression, substance use, etc., etc. But there is going to be huge increase in mental health problems. There are already indications. I mean, the last 3-4 weeks, I've been in India watching the news every day, all over the country, and also Kerala, which has been highly commended about the way they dealt with the COVID. They are having a surge, and every day the number of suicides which are reported is an indication about the things to come. A huge increase in mental health problems, as well as the mental health consequences of the economic downturn. In fact, I read a few days ago that the years after 2021 will be similar to the years after 1945. I think this was Bill Gates talking about future pandemics who said about this. So the enormous economic consequences. We have a little taste of it about the debt crisis in Greece and Italy and Spain less than a decade ago, how the suicide rates went up, etc. That would be something that we need to deal with. On a positive side, I think wider and increased awareness of mental health issues, the fact that a similar webinar of this nature late evening is inaugurated by the Union Health Secretary in the presence of the economic advisor to the Ministry of Health and Family Welfare is an important indication that the government of India at the highest level, as also in many other governments. I know I was in Australia a few weeks ago. In fact, one of the few things there has been bipartisan agreement. The two parties, the two poles keep fighting all the time, but one of the things on which there was very unique agreement was funding for mental health. Almost $1 billion were released for, the telemedicine and things like that. So will this be an example? Will increased funding occur in other countries post-pandemic? I put 3 question marks because I don't know. Because there is going to be a huge economic downturn. And at that time, to expect a higher funding for mental health to improve services, one is doubtful. I believe that there is probably a slight reduction in stigma. People are talking about mental health because there's such huge increase. So that is also perhaps on the positive side. Now uh, the rapid advent of delivered healthcare for non-essential service, the telemedicine, the thing that Lakshmi referred to, the digital. I'm only raising some questions because after me, Keshavan is going to talk about research issues, etc. I'll raise some questions. Will telemedicine become the mainstream form of patient interaction? I have reasons to believe that probably we are in that direction. Can video visit fully substitute for an in-person visit? We are still waiting for this. This is something need to be researched. We need to carefully look into. What will be the preferred model? Again, I think already there are some indications that people, I mean, for a few months, March, April, May, till end of May, I was working in Australia, working with the telemental health and digital, etc. And a lot of people said, oh, even after the COVID, maybe this is a good way of, connecting with the doctor. You don't have to travel, you don't have to wait in the practice or in the outpatient room, etc. So maybe this will become a preferred model. But for millennia, the laying of hands represented the essence of the doctor-patient relationship, the human touch of the carer. I'm quoting Eric Topol, who has written a book on artificial intelligence much before the COVID started in 2009. I'll show you that book. So he talked about that. So isn't being physically apart antithetical to the essence of medicine? And also, of course, psychiatry. Can remote care facilitate transfer of trust, empathy, and compassion? I'm sure Keshavan will have many more points for his research agenda. And I will now close with showing you the title of this book. It's a very interesting book. It's written by Eric Topol, whom I quoted a little while ago. It's called Deep Medicine: How Artificial Intelligence Can Make Healthcare Humane Again. Of course, this is before the COVID, or before he even knew about the pandemic. He had written maybe last April 2019 or so. It's an interesting reading. Thank you very much once again for a patient listening. Back to Naveen.
Thank you, sir, for highlighting the lessons to be learned from the past pandemics, flagging the fault lines and challenges lying ahead of us. I now request Dr. Neha Kulkarni to introduce us to our final speaker.
Thank you, Dr. Bhavika. Our last speaker of the day, Professor Matcheri Keshavan, who's the Stanley Cobb Professor and Head, Department of Psychiatry, Beth Israel Deaconess Medical Center, Harvard Medical School. He is the editor of Schizophrenia Research Journal, with his areas of interest including psychopathology, biological psychiatry, including anatomical and functional neuroimaging, neurocognition and neurodevelopment, genetics in schizophrenia and bipolar disorder, and many more, who is one of the principal investigators of BSNP project with more than 1170 publications in both national and international journals. He has been the recipient of many honorable awards. I invite Professor Matcheri Keshavan to throw us a light on research in public psychiatry during pandemics. I welcome you, sir.
Sorry, I unmuted myself. Do people hear me?
Yes, sir.
First of all, thank you, Neha, for that introduction. And also, thank you for the organizers, Naveen, Pratima, and Gangadhar, and others for making this wonderful event, very timely event possible. I know that we are running late into the event, and I'll try to be brief. And my job has been made easier by all my illustrious predecessors in this event. And what I'm going to do is to point out the research directions that we should be, as a global mental health community, be pursuing in the years to come, and the fact that the COVID pandemic has given us an unprecedented opportunity. I'm trying to move my slides here, and this is not exactly moving. So let's see here. Okay, yeah. So as I said, COVID-19 is a global stressor that has, come upon mankind, and can be viewed as a natural experiment upon this world. And during such a pandemic, while we have several disastrous consequences that we are dealing with, this may also be an opportunity for us to reflect upon the nature of this pandemic and what it might reveal to us about the mind and the brain, and about the future practice of psychiatry altogether, as Mohan Isaac said. Interestingly, as this cartoon points out, it was during a pandemic, the Great Plague of London in the 17th century, when there was a quarantine, and Sir Isaac Newton was essentially isolated. That was the period during which he discovered the groundwork for his theories of calculus and the theories of gravity and motion. So this may be the time when we are sitting at home, but we have our minds and our data to look at and actually think about potential new solutions that we hadn't thought of before. Now, Mohan also pointed about the importance of learning from our past. It has been said wisely that those who do not learn from the past are doomed to repeat the consequences of the past, repeat the mistakes of the past. So we have to look at what has happened in previous pandemics. And the one pandemic that is well known to everybody is the Spanish flu of 2018 or 19. As many as 500 million were affected, and about 50 million people died. And the number of new hospitalizations for mental disorders increased by 7-fold over the 6 years after the pandemic, which included depression, anxiety, neurasthenia, neuropsychiatric complications, including what became known as encephalitis lethargica with Parkinsonian features. They all emerged only years later. So the main lesson for that is this is the time to begin research and understand the nature of post-COVID neuropsychiatric disorders is now, and it has to be started proactively. And this is a slide Lakshmi showed earlier on. It's a very insightful slide, points out the fact that what we are still in the middle of is this first wave of the immediate morbidity and mortality of COVID-19. What we are beginning to see, and what will become more problematic, are the subsequent consequences of the resource restriction, the economic declines, the non-COVID conditions, which were kind of not receiving treatment, re-emerging back into the hospitals, and the post-ICU complications, and so forth. And also the trauma and the psychosocial consequences of the pandemic leading to psychiatric disorders. It is these disorders that we have to anticipate and take proactive ways to understand and intervene. I recently wrote a paper in which I outlined a research agenda for the COVID pandemic and the kinds of questions that can be framed as priorities. So if you think of this as a major group of disorders, we have to understand what are the risk factors as well as what are the resilience factors. And the previous speakers have outlined the important factors such as medical comorbidity, personality factors, environmental factors such as smoking, social distancing, loneliness, unemployment, economic decline, race, underprivileged communities, urbanicity, and air pollution, we had to study these multifactorial origins of psychopathology and negative consequences of COVID, and also understand the presentations of these various psychosocial consequences that we will see, or we are beginning to see, either new onset or a exacerbation of pre-existing anxiety, depression, psychosis, obsessive compulsive disorder, post-traumatic stress disorder. Dinesh pointed out the importance of looking at intimate partner violence, which we are already beginning to see a pattern of cognitive declines and dementia. Lakshmi pointed out social rhythms disturbance, which may have an impact on mood disorders and so forth. We're also beginning to see the world is changing around and developing quick solutions to healthcare resources, delivery, and approaches to care. And we have to see how they are working. Are there alternative ways? Should healthcare policies change? And telepsychiatry and digital psychiatry, which many of the previous speakers have commented on, is almost coming to the center stage at this point. Now, in this slide, I wanted to put together the model of how we understand COVID-related neuropsychiatric complications. One has to think of these as an epidemiological triangle with the host, that is our own body and our own immune response, the agent, which is the virus on the left side, and the environment. All of these factors interact to produce the consequences that we are beginning to see. And those include all of those that I mentioned before: social, economic, demographic, and pre-existing illness-related factors, as well as access to care, medication and iatrogenic effects, medical comorbidity, and even genetic risk. All of these will have to be considered in our understanding of the nature and evolution of psychopathology. And we know that these illnesses have a time course. There is an acute infection. Many people, thankfully, recover without symptoms, and some who have symptoms may have mild symptoms, and thankfully a small proportion, which varies from country to country, maybe around 5% on global average, develop an acute severe inflammatory response due to what is called a cytokine storm. And that may lead to its own neuropsychiatric consequences like delirium and cognitive declines, and may be followed by several downstream psychosocial consequences. An important question that has to be understood prospectively is whether conditions that cause an ongoing chronic inflammation due to pre-existing medical illnesses like obesity, autoimmune disease, arthritis, diabetes, hypertension, depression, do they all predispose to a higher chance of developing cytokine storms? And do they also predispose to a higher chance of subsequent neuropsychiatric sequelae? Now, this is a cartoon which is also circulating around, which is very insightful. If you carefully look at this, there is the acute wave, and which can be flattened by a strong collective response, which is the best case scenario. But if this strong collective response by the community and the public healthcare systems are inadequate and are short-lived, that would lead to a subsequent surge again of both of the COVID virus as well as of the mental health consequences. So one has to develop a response both at a community level and at a healthcare system level, adequate and consistent collective response, which is not only comprehensive to begin with, but also sustained in the longer run. So that is the key point that requires national and local level leaderships. And it was I was proud to hear Gangadhar's presentation of how NIMHANS is taking a lead for the country and perhaps for the world on developing a collective response in that way. There are many things that are beginning to change. It has been commented by previous speakers about the rapid shift that is happening to telehealth. In my own system in Boston, we have seen that almost 90% by now of outpatient care has been switched to telehealth. And even inpatient settings, we are walking around with iPads and sitting in this central room and having teleconsultation with patients sitting in their ward rooms and so forth. And the same thing is happening with consultation liaison settings as well. So what are the strategies for developing a research plan and a research agenda? There are many ways in which data can be harnessed for benefit in understanding COVID-related mental health consequences. One could use existing health records, where electronic health records are available, which can allow linking between mental health, medical, and community health services to identify patterns and trends, both in clinical populations as well as in individuals with suspected or existing COVID-19. It's also useful to capitalize on existing cohorts of already well-characterized populations. Like the UK Biobank is one good example, with large numbers, thousands of people whose clinical characteristics as well as biological specimens have been characterized. The same thing with many large studies like VSNP and NIMHANS like ADBS and so forth. And such platforms might also have recruitment platforms which will allow these individuals to be brought back. And if they have been exposed to COVID, how do they respond, and can we learn anything about their baseline characteristics about who does or does not have negative consequences? Also, it's important to initiate population studies in vulnerable populations like children, frontline healthcare staff, people who have survived severe COVID-19, and so forth. For example, we are in my own hospital in Boston, we are beginning to start a COVID clinic for people who have been discharged from intensive care units, and we'll be prospectively following them up to understand what's going to happen over the next few months or years. What are the principles of good research practice? First of all, one needs to conduct both hypothesis-driven as well as hypothesis-generating research. The hypothesis-generating research would involve collection of large-scale agnostic data that are obtained in a way that could lend itself to measurement-based care. Study designs need to be rigorous, ethical, and would need to consider general population as well as vulnerable populations. When we say measurement-based care, we not only provide care for patients, but also we measure what we are providing, the care we are providing, and also the responses and their psychological and physiological changes over the course of time using biomarkers and so forth. We also need to involve multiple stakeholders, patients, those with lived experience, the public, the policymakers, and so forth. The research has to be interdisciplinary, and what Gangadhar outlined was a great example of collaborations between disciplines such as psychology, psychiatry, epidemiology, neurology, neuroscience, and so forth. Data need to be harmonized, and methods need to be harmonized across multiple settings. And also international collaborations. The more the data, the better the answers will be. And so collaborations are already emerging internationally of consortia that are beginning to collect data in a uniform kind of way. Now, one idea that I want to throw out here, I'm sure somebody is already doing it, but I think NIMHANS could take a lead on something like this. And the one testable hypothesis is, if you look at all the medical conditions and the demographic conditions that are associated with the higher risk for post-COVID consequences, as well as the COVID infections themselves, these are things like obesity, metabolic syndrome, chronic medical diseases like arthritis, sedentariness. What is common among all of those? One thing that is common among all of those is what is often termed the concept of allostatic load. Dinesh pointed out one other concept of COVID age, And I would argue that COVID age may be related to the degree of accumulated stress in the body that, that throws the individual's homeostasis away. In other words, the body is thrown out of balance. And what is it that can reverse this kind of imbalance? It may be that exercise, healthy diet, good sleep, yoga, and meditation may move individuals towards a more of a homeostatic balance. Institutions like NIMHANS, which have a world repute on an empirical study of lifestyle interventions like yoga, could take this as an opportunity and collect data on outcomes of people who are exposed to COVID, as well as those who are not exposed to COVID, as well as those who have been exposed and have had infections and other consequences, to see whether pre-existing parameters of lifestyle can predict resilience towards negative consequences, and also whether introductions of healthy lifestyle interventions could make a difference. And of course, for such research, one needs a comprehensive, systematic, prospective study that involves both psychosocial and biomarker-based assessments of data. That's a large-scale effort, and it's very important that national organizations and international collaborative opportunities should be looked into for these kind of questions. I think that's so. Biomarkers might include simple measures like C-reactive protein, cortisol, heart rate variability, sleep quality, and so forth. So take-home points are COVID-19 is a huge challenge to health and mental health everywhere. COVID-19 is a natural experiment that offers an unprecedented opportunity for mental health research. Several important questions pertaining to causes, presentations, trajectories, and treatments of mental illness can be addressed in the context of COVID pandemic. I would stop here to say, when Mohan asked the question, what's in future for us, this may be an opportunity for psychiatry to bring the body and the mind together, and also to bring large-scale resources to address the mental health issues, the challenges the fault lines that Mohan pointed out. A lot can be gained by embedding COVID-related questions in the context of ongoing studies, as well as new studies of vulnerable populations. And as many of the previous speakers have also said, e-health and digital health are rapidly assuming center stage, and prospective, proactive research is needed now to gather actionable evidence while we continue to do what we can do to mitigate mental health consequences of COVID-19. Leadership is critically needed more than ever, and it is amazing to see how NIMHANS is taking the lead here. Thank you.
Thank you, sir, for enlightening us on the strategies that we could use related to the mental health research. I now request Professor Matthew Vargas to moderate the question and answer session.
So thank you very much to all the 5 speakers who did an excellent job. And I think this webinar will be something that will be watched many times over in the next few years. Let me start by asking a question to Keshavan, who just finished. So Keshavan, in terms of research, are you suggesting something like the worldwide solidarity trial, similar study for mental health? And maybe it's something that, since you already have some thoughts on it, and maybe you and Lakshmi and Dinesh from the Institute, and maybe Mohan from Western Australia and NIMHANS, we could think of a very large sort of international study looking at this, harmonized research. Do you think that's a thought, Keshavan?
I think you read my mind, Matthew. Absolutely. I mean, I don't know much about the solidarity trial, even though I've heard about it. And, if there is any way in which we can bring all of us who are interested in this important problem together, that'll be fantastic.
Great. I think it's something for Pratima and Gangadhar to think of.
Matthew, can I just jump in and add a quick point? Just mostly from the logistical perspective, I think it's a great idea, but I guess one also needs to think about logistical challenges and the time it might take to pull something like that. And I think one of the things with the pandemic is it's unclear how this is going to evolve and how long it's going to last. And I think in BC, we try to harmonize the data so that we have a common database for all patients that have been affected with COVID-19. And we spent really last 2.5 months trying to figure out all the processes. And during that period, I would say we've lost a lot of valuable time because most of the patients now have recovered, at least from the acute phase. So I think while the idea that Keshavan mentioned is a really good one, and I think as we wait to implement that, I think it shouldn't stop NIMHANS from taking the leadership and implementing that in India right away, because I don't think you should be waiting for this to become a global effort, because that might take quite a bit of time, during which one might lose valuable amount of time. So my suggestion is it's a great idea, but let's start with NIMHANS, because NIMHANS has shown an incredible amount of leadership in addressing this COVID challenge.
Thank you, Lakshmi, for those comments and also suggestions. And I think that's something that we need to really look at. Mohan, a question to you. You said learning from the past is important, and learning from the Spanish flu and other disasters that we have had in the past. Do you think you are positive in sense of saying that this might actually push us towards doing a lot of teleconsultations and telehealth? Do you think telehealth will be the game changer in terms of reducing the treatment gap? And do you think that in a world that was so far very unconnected, do you think that this will actually improve social connections between people, not just families but also our patients and ourselves?
Okay, let me just respond. Let me make firstly 2 points. Telemedicine is not anything new. It has been there for the last 10 or 15 years, but it was only for remotely located rural populations, indigenous population. In fact, I have myself done a review of the SCARF telemedicine project in Pudukkottai district, which was funded by the Tata Trust, a major program. Tara and others sitting in SCARF would review patients in Pudukkottai. Pudukkottai is the least developed district in Tamil Nadu. So telemedicine has been there. But what is important to note is that from the time the COVID pandemic started, how swiftly we have moved to, not only in advanced countries, Gangadhar told us about how that is being applied even in India. So now the question is, that was some of the questions that I raised. Once the COVID settles down, we don't know when, we've heard from Lakshmi also, maybe 2 years later, but I think this too shall pass and there would be something called the normal again. Many people say that it will not be the normal that we are familiar with, it will be a new normal. But at that time, will telemedicine be the preferred mode of consultation? My guess is that it will be. Now, Keshavan just now said that 90% of all the consultations in Boston is already occurring. I also had misgivings whether they would work. I have raised some of my concerns. Can you transmit empathy, concern, trust? As doctors, we have always seen patients face to face, etc. So I think this will be the game changer. This will be the main mode. And there would be a lot of people, not for essential services, not for serious problems, but for mild to moderate problems. The anxieties, the depression, and various other problems. I think the digital, virtual, tele method would be the mainstay. And to give you an example, social media, even in India, the number of people who are linked to social media, WhatsApp, and all kinds of things, the numbers are rapidly increasing. And the success of all those providers, service providers who provide social media is an indication that telemedicine would be an ideal method for consultations in future. It would be also cost effective.
Thank you, Mohan. Dr. Gangadhar, this global pandemic which has come to India has actually pushed up the issue of healthcare in our country. And I think all over India, healthcare is really being ramped up, and also mental health care. So the district mental health programs and other people on the ground, especially mental health professionals, are really being pushed into the field. Do you think that this will actually push the district program and the health program of the country in a big way? Because we are talking about MBBS courses, MD courses, we are talking about fast tracking things. Do you think this will be a game changer as far as healthcare in India is concerned?
No, number one, it has alerted us about the importance of public health, whether for the physical health or mental health. I, as a psychiatrist, believe that public health should come in the fore, and we should move out of hospitals as much as possible, and the resources spent on the hospitals, if a part of it is spent on the public health agenda, we would probably be giving a better care to the population. This is number one. The other issue which I think I should air with Dr. Keshavan is a tremendous opportunity for research. We should consider maybe initiating a large inter-center collaborative study following up a cohort of population who has gotten infected and who has not gotten infected over a couple of years or maybe more numbers of years, to be able to see what are the outcomes of this corona infection in terms of psychiatric morbidity, mortality, or any other developmental or progressive phenomenon that we may see. This is a very good opportunity, and I think we have now visiting professors from 4 different countries. I think this is the right time to start a multi-center follow-up cohort to be able to unravel this question. I'm sure the younger people in all these centers will be able to take up and put up a big proposal for examining this question.
Thank you. So this is something that can, I think, get funded at this critical moment. Dinesh, there was a question for you. Thanks, Dinesh, for bringing this double or even triple whammy that the underprivileged are facing in terms of having more physical comorbidity, not being able to afford healthcare, and increased violence. Now, there's a question that somebody's asked which says, how do institutions and hospitals look after the mental health care of the healthcare workers and also of the underprivileged? What strategies can we adopt?
Thanks very much, Matthew. I think before I answer the question, can I just go back to the sort of telemental health question? I think it's incredibly important that we don't jump on the bandwagon in that, yes, telemental health changes the concept of care. I spend some of my time at the Tavistock, which is, as most people would know, as history of psychoanalysis. And certainly the older psychotherapists are complaining that they can't share, show, display empathy, whereas younger generation does not see that as a problem. So I think we need to be looking at what do we mean by empathy, and that in context of privacy and confidentiality is going to be the key whether telemental health takes off or not. The question about what we should be doing, I think it's absolutely vital that the institutions look after the mental health and well-being of their staff. And again, in a series of surveys, we've shown that the rates of burnout among doctors and medical students pre-COVID were something between 30 and 40% in some medical schools and 95% in some medical schools in Hong Kong, for example. So there are questions about what we need to do. I think there are 4 levels of interventions. Each of us has to be responsible for looking after ourselves. and looking after those around us, whether it is at home or at work, team members. Institutions have a moral responsibility to look after its staff by making sure that access to occupational medicine, occupational health is available readily, easily, and is well supported. Then there are the kind of third level is more at a sort of regional or state level as to what organizations need to support each other, because there are questions about confidentiality. For example, I mean, in Bangalore, if NIMHANS staff are feeling under stress, how free are they in accessing services within NIMHANS? So should they be have some kind of mutual agreement with St. John's, so they can go to St. John's and people from St. John's can come to NIMHANS in a similar way? And fourthly, at the sort of national level, medical councils have, and nursing councils, and equivalent bodies in other healthcare professionals have an ethical and moral duty to make sure that services are available and accessible. I mean, we found in a survey in the UK that medical students generally do much better in seeking and getting help, whereas junior doctors do very badly. And we know that junior doctors and those who graduated, medical students, within the first year of graduation are really stressed out, and they find it very difficult to seek help. So we need to be investing as a profession to make sure that services are accessible and readily available without stigma. And if we cannot provide those services without stigma, then we can't go around criticizing other people that they have stigma about mental illness.
Thanks, Dinesh. And I think that systemic perspective in terms of primary, secondary, and tertiary preventions is very important. I think research shows that it's really the larger systemic interventions that are really useful. If somebody has depression and anxiety, the interventions are less likely to help, as opposed to actually preventing it from a very systemic, larger institutional and national perspective.
But I think one of the, sorry, Matthew, I mean, one of the key things is that a lot of surveys in COVID are showing anxiety and depression. The question is, are these kind of genuine, appropriate responses, or are these illnesses? Because if we create more demand for our services and we can't deliver that, that is going to add to the stigma.
Right. Yep. So Lakshmi, there's 2-3 questions for you. Thank you very much for all that research that Canada has done on the COVID situation, especially the systemic responses from British Columbia. There are 3 questions. One is, how do we prevent suicide? What are strategies to prevent suicide among the healthcare workers? That's the first question. And the second one is on the effect of COVID on sexual health.
Okay, well, let me start with the first question, and that is, I think the early identification of the mental health impact is the key, I think, because things don't change overnight with the frontline healthcare workers. They're obviously constantly exposed to number of stressful factors related to providing care for people with COVID-19. And so what we had done within our system was to organize the psychological first aid. So we assembled a group of experts within our system, and the team was readily available to provide help for anyone that needed help. The access was the key. So in other words, they didn't have to wait for several days before they could see someone. So the help was available quite rapidly. So that I think that was one of the things that was very helpful. And the second thing I think is also access to the crisis lines that we had implemented in our system. So there again, if a healthcare worker is concerned about seeing a team within the healthcare setting and their concerns about privacy, perhaps then they can call the crisis line and get that support. And then the third thing that we'd organized is working with the physicians organization within our healthcare system. We set up a virtual mental health clinic. So people that have accessed the psychological debriefing or psychological supports, if they didn't feel that their needs have been met with that kind of strategy, and if the concerns are, a bit more serious, meaning that they've sort of moved on to having a major depression or an anxiety disorder or psychosis or bipolar, then there would be a rapid access to more formal psychiatric assessment and appropriate treatment interventions. So I think the key is offering easy access or rapid access to frontline healthcare workers, and providing help earlier on, I think, is probably the best way to address those suicidal thoughts and that leading into actual suicidal attempts. And the second one was about the sexual health. Matthew, was that it?
That's right.
Yeah. So I think so we have a member in our department whose expertise is in fact sexual health, and she's actually been doing a number of surveys to understand the impact of pandemic on sexual health. And of course, when the pandemic began, the general impression is that people are spending a lot of time at home. They have lots of time on their hands. So there's going to be significant increase in sexual activity. There's a baby boom, those kinds of things. But what the preliminary data are suggesting, she hasn't analyzed the data in detail as yet, but from what they've looked at in terms of the preliminary analysis, it's actually indicating that the sexual activity during the pandemic, for vast majority of people, not for all, for vast majority, has actually gone down, mainly because of the stress and anxiety and those kinds of things. But interestingly, for a small proportion of people, it has gone up. And I think her hypothesis is that it's perhaps for this small group of people, it's a way of coping. So for vast majority, it leads to decrease in sexual desire, the activity goes down, but for a small proportion of people, it's a way of coping, and so it does go up.
Thanks, Lakshmi. For you, which is from Dr. Prabhat Chandra. She says, you mentioned trauma in passing. How would you conceptualize COVID-related trauma as being unique? And what are the kinds of research questions we can explore in that area?
Yeah, so again, you can look at the trauma from the individual that has been admitted to hospital with COVID-19. You can also look at the trauma from the family member's perspective, or even from the frontline healthcare workers' perspective. So with the individual that has contracted COVID and has been in the hospital, of course, there's the issue of watching other people on the units going on ventilators, going into coma, and all the activity that goes with it. And also the patient himself or herself going on the ventilator and the trauma and the fear associated with that. And for healthcare workers, I think if one watched what's happened in China, particularly in the earlier days of this pandemic, one has heard a lot of horror stories. And you can also imagine the trauma from the relatives' perspective, where they know that their loved ones are in the hospital, but they can't even visit. They have to see them through a glass window, things like that. In terms of, what are some of the research questions that could be addressed? I think I sort of alluded to in my presentation, a lot of the data that's come out so far is based on very poor methodologically based kinds of studies. So we have some ideas, but we don't really understand how this is going to be impacting. I mean, Dinesh brought up the point about a lot of people endorsing anxiety and depression, but is this sort of a normal response one might expect given the pandemic? Are some of these people actually transitioning into the DSM and ICD disorders? So we don't have firm answers as yet. And Kesh talked about this offering a natural experiment to study. And I think what we know with this COVID-19 virus is that it does have a significant impact on the immune system. And we know that immune system alterations have been implicated in the neurobiology of many of our psychiatric disorders. So in a way, this might present an opportunity to study how stress impacts glucocorticoid system, the immune system, adrenergic system, and how those changes in those things interact with some of the predisposing factors and the resilience factors that might eventually determine who ends up developing, for example, whether it's a PTSD or other type of anxiety disorder or depressive disorder. So in other words, looking at those different types of cohorts and propensity matching, looking at the exposure to some of these events, and then perhaps collecting blood samples for some of those measures and doing a comprehensive clinical assessment to collect some of those data related risk factors so that one can then begin to model how these factors interact that ultimately determines who ends up developing these disorders. So, and I think given the number of cases that you're seeing in India, I think, and I agree with Kesh that this presents an amazing opportunity to answer many of the questions that we wanted to answer.
Thank you very much, Lakshmi. I think I'm mindful of the time that we exceeded by about 25 minutes, but I just couldn't let the speakers go without some discussion. So I think I've covered all the questions. I don't know if there's anything from the Facebook or the sort of YouTube questions. Are they?
No, sir. No, sir. No questions.
Okay.
Avdesh made a comment about what we are doing for media people, how we can use the media to come up with the primary prevention in mental health. Yeah, it's a good question. I just want to bring it to the rest of the audience that the Mental Health Education Department is holding a webinar tomorrow for media persons as to how their presentations on COVID could make a different impact, more positive impact in individuals, to be able to help them out of this crisis of mental health pandemic in COVID.
Yeah, thanks, Gangadhar. I think there's one more question from Murli. I think I've covered all of them about early interventions going out the window, but I think that's Murli can sort of probably talk to Lakshmi about that. Early interventions in schizophrenia and bipolar. I think I can go. I'm going to hand this over back to the organizers, Naveen and Co. Thanks a lot for letting me moderate this session. Thanks very much. And I think we should take some of these ideas forward. Thank you.
Thank you all. I request Professor Naveen Kumar C to deliver the concluding remarks.
Thanks, Bhavika. And I must say, I think it's been a wonderful experience having all our senior professors, coming in and connecting virtually for this excellent program. We had a feast academically, touching upon various issues of COVID and mental health. Actually, I mean, starting from the Health Secretary, Madam herself, she talked about the importance of mental health and COVID, and Professor Yatham about the work that has gone on in Canada, and of course, Dr. Bhugra speaking about the underprivileged population, and Professor BNG talking about the initiatives that has been taken in NIMHANS, and Professor MKI talking about practice in psychiatry post-pandemic. And of course, the icing on the cake was a talk on what research ideas can come up and how to take this forward. And of course, a lot of ideas have come in. And as Professor Matthew Varghese rightly put it, some of these things need to be taken forward. So I thank you very much, one and all, for having spared your precious time and spending time with us. We are indeed privileged and hope to see you all. Thank you.
Thanks very much. Take care, everyone.
Bye.
We would be ending the meeting for all now. Thank you all.
Thanks very much, everyone. Stay safe. Bye for now.